that these rights, the highest attainable and standard of health, which includes the right to health care services, including reproductive health, that every Kenyan should enjoy that. So these are all aspects of universal health coverage. And you see, in the year 2000, the world came with something they call SDP, Sustainable Development Goals. Goal number 1, there should be no poverty. We are going to eradicate poverty. Goal number 2, the world is going to be free from hunger. Goal number 3, SDP 3, that there should be good health and well-being for entire mankind. And there were certain deliverables that were made. One of them was to reduce maternal mortality at least by 70 per 100,000 deliveries all over. Some of us right now, like Kenya, is having maternal mortality of about 400 per 100,000 live births. So we are saying by 2030, we should be having those deliveries only 100,000 deliveries, will only have 70 maternal deaths. And the goals are there. We are supposed to reduce infant mortality. We are supposed to reduce neonatal mortality. We are supposed to have universal health coverage globally so that everybody enjoys good health and well-being. We are supposed to reduce injuries and deaths from road traffic accident. And the list is endless. You know, those are just documents that are available and you can read through. And some of those things are interchangeable, intertwined, interdependent. Poverty, free from hunger, will improve good health. Then there's good quality education. People educated will also have good health. Freedom, justice, the list is there. And, you know, health is good and good sleep is good. You all remember that SDP 3 is good health and well-being of people. You remember the hadith that Prophet Muhammad sallallahu alaihi wasallam said, there's a man who will come through that door and this man would enter paradise. So this Sahaba entered. Next day, the Prophet said the same thing and the same man entered. The third day, Prophet sallallahu alaihi wasallam said the same thing and that same man entered. Then one of the Sahabas was very excited and wanted to know, very anxious, why is this Sahaba going to enter paradise? And he said, I would like to be your guest for the next few days. So he was the guest and he stayed there for several days. And you know the rest of the story. But who pays for that health? And what do they pay for? Is it out of pocket? Is it insurance? Is it the government? You know, these are all questions of money. And there are challenges of universal health coverages. One of them, you are very familiar with that. No human resource, no human capital. And then of course, wanasema wanataka haki yao, because there's no money. And one of the things of Abuja Declaration of the year 2000, African governments committed is 15% of their national budget on health. But if they were to do that, and our budget right now is about 3 trillion shillings, they will have been using about 50 billion on health. But right now, what they put in health is just about 5%. And that is why we have all these problems. I was looking at dialysis in one private hospital over 2 years, 2017 and 2018. And these are, the NHIF package will say that each person is allowed 2 sessions and certain medications and free consultation, that is debatable, and laboratory tests monthly at a cost of 9,500. Of course, this is the payout that they had in 2017. They paid 840 million for dialysis. Half year 2017, they had had 86,000, and here they had had 37,000 dialysis. And this is what they paid for last year. And for kidney transplant, they pay about 500,000 shillings per transplant. Of course, what we have realized over that period, in 2015, this was the way renal dialysis was financed. In 2016, the numbers shot up, and people who were paying out of their pocket of this much, and NHIF was paying this much, and emergency sessions had reduced because of NHIF contribution. In 2017, out of pocket and other insurances almost pulled out, and it was only NHIF which was paying almost everything for that. And then, of course, dialysis sessions and the payment, you will see this is what we have as the increase. But there are extra costs. Who will put the cannulas, the extra lab works, and whereby there are other things, blood transfusion, those ones are out of pocket. And when there's resuscitation, ICU care for those people, other people will pay for it. What I will say in conclusion is UHC, is it right fundamentally? And we say the SDGs and the Kenya Constitution emphasize that. And NHIF payouts have been increasing. But what will I advise is this: there should be changes in laws to insurance to complement NHIF, because right now, whenever NHIF is taking over a product or a package, all the insurances pull off, and that is putting a lot of strain and might lead even to the collapse of NHIF. Asanteni sana. And that is the bend that we have to travel to achieve universal health coverage. Asanteni sana. You are all familiar with that. And I wish to thank all those people who assisted me in conducting the study. Thank you all for listening.
Allah Jazakallah khair, Dr. Marjan. We saved us 2 minutes. So we are now in schedule. We are 2 minutes behind, now we are on track again. And please don't throw any sand on my face. I was not flattering. I was sincere, true. He is one of my role models. And now it gives me great pleasure to invite another person who is a role model for me in my life. A certain degree impacted me to go the direction I'm going in. I went in for a physician to into nephrology. He is none other than our brother Dr. Ahmed Tahir. Dr. Ahmed Tahir, we know he's a very senior and experienced nephrologist. He is currently the chairman of the Kenya Renal Association, and he runs on, he's a clinical director of Parklands Kidney Center. Not flattery. True, sincere recognition. Karibu sana. He's going to talk to us about ethics of kidney transplantation. Karibu.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Dr. Ibrahim, for those kind words. I also want to thank the organizers for inviting me for this third camp meeting. I think it's very important that we all meet here as Muslims to share and learn from each other. So without wasting too much time, I'm going to embark on the topic of my discussion, and that's ethics of kidney transplantation. So when I was asked by the organizers to give a talk, it was quite difficult to choose a topic that I thought would be enjoyed by a diverse audience. So I felt that a topic on ethics on kidney transplantation would be appropriate. So kidney transplantation, basically the surgical aspect is fairly straightforward. We take one of the kidneys from a donor and transplant it into the recipient. Many people actually think that we remove one of the native kidneys. We leave the old kidneys behind. So many people with a kidney transplant will actually end up with 3 kidneys, the 2 old ones and the new one, and hopefully it will be functioning. So the title is ethics. And what is ethics? According to the Merriam-Webster dictionary, ethics means the discipline dealing with what is good and bad, and with moral duty and obligation. Doing transplants is challenging, not only because of the technical aspects of the surgery and the aftercare, but also in choosing your donors and recipients, as you're going to see from the next case. So for example, this is a 55-year-old patient with diabetes and a strong family history of diabetes. Means many of his other family members have also got diabetes. His blood group A positive. His father died with diabetic end-stage renal kidney disease complications. He was on dialysis for several years. And Mr. D is currently on hemodialysis for the last 2 years. He wishes to have a kidney transplant, and currently his 60-year-old brother, who's not diabetic, is willing to donate, but his blood group B positive. And Mr. D is blood group A positive. And you know that Mr. D can only receive a kidney from blood group A and blood group O, which is a universal donor. So his 60-year-old brother cannot donate to him. So what are his options? He's got a 25-year-old son who's the only child. The other option is his 60-year-old brother, although he's blood group B positive, maybe they might be able to exchange with somebody who needs B but has an A donor. So that's called a paired exchange program. It's not available currently in the countries, and it's developing in many parts of the world where you actually exchange kidneys. His other option is he's got a good old school friend who's willing to donate to him. Should we allow that option? His employee is his houseboy who's worked for him for the last 20 years. His houseboy is willing to donate for him his kidney. Should that be allowed? The other option, he heard that in China you can actually go and get a kidney, because when the prisoners who are on death row, when they are killed, their organs are actually given out to hospitals that are willing to use them for transplantation. The only thing is he doesn't have 12 million Kenyan shillings to travel to China for an organ transplant. His wife is willing to donate to him. Should we allow his wife to donate to him? The other option, and that happens many times, is he remains on dialysis for the rest of his life because he doesn't have a donor and he doesn't have enough funds to travel abroad to buy a kidney. And I want you to think about these issues issues as we go along in our presentation, and maybe during the discussion time we can come up with some ideas. There are no, I'll tell you from the beginning, there are no very good answers, and that's why even in the hospitals, before we do a transplant, we sit down as a transplant committee and discuss, should we allow this transplant to go on? If yes, what are the challenges we're going to face? We involve counselors, we involve the hospital ethics committee, we involve the social workers, and it's a big team. And by the time we accept for a patient to donate, we've actually gone through a very vigorous process. The other case scenario, which is quite interesting again, Mr. X is an employed poor driver living in Yemen. He wishes to sell his kidney to a rich Saudi prince for $20,000 US. That's about Kenyan shillings 2 million. This will enable him to buy a car, to start a taxi business, which will feed his wife and 5 children. Should we accept him as a donor to this Saudi prince so that he can live a normal life and look after his family and children? So again, I don't have any straight answers to this, and let's see, maybe as we go along with the presentation, we might learn a few things and maybe come up with some better answers. Kidney transplant, successful kidney transplant. The US, it was 2 monozygotic twins, so it was fairly straightforward because rejection was not a challenge here. And these are the donor recipients. They're twins, so it's difficult to know who was who. And in Kenya, we were not left behind because many years later, we actually did our first kidney transplant, although it was a fluke because it was not planned. A young girl who had a horseshoe kidney, mistaken it to be an abdominal mass, ended up having the mass removed, and obviously after the surgery the patient was not passing any urine. This was in Nairobi Hospital in 1978. So at that time, the patient had died in the ICU, and the family were willing to donate a kidney to this patient who had been done a nephrectomy. And the patient actually lived for 1 year. So that was a fluke. But then in 1984, which was about 30 years after the world started doing kidney transplants, Kenya started doing regular for kidneys that are not there. That's why there's all these illegal things going on. In Kenya, as I've said, we've been doing transplants from 1984, but from 2006 we've actually been collecting data, and the number of transplants have been increasing. Last year we did 75 transplants in the whole country. This year up to now, which is in March, we've done 23 transplants. We have about 7 centers doing transplants in the country now, again with very good success rates. And I say this because we've been monitoring the patient outcomes, and maybe in another presentation or at another forum might be able to present the outcomes of kidney transplants that have been done in this country. Unfortunately, even though we are increasing in our transplants, the demand for kidneys is very, very high. As you can see, the dialysis patients are increasing. See, when we started dialysis about 20 years ago, the number of dialysis patients were quite few, about 120. They've been slowly increasing, but only until 2015-16, when NHIF started supporting, the numbers have increased exponentially. Currently, we have 4,300 patients on dialysis in the whole country, about 50 government supported, 50% are government supported, the rest are privately owned institutions. And this is creating a huge burden to the government, as you saw from the previous presentation. You've gathered by now that we can have two types of donors. There's a live donor, from our two cases we presented. They could be either related by blood or marriage. So a spouse is considered as an appropriate donor. Non-related directed donation. So a friend is non-related and he can say, I want to donate to so-and-so. And humanitarian non-directed donor donation, where an individual just comes and says, I want to donate my kidney. I don't mind who receives it. I just want to donate. And then a paired exchange program, which I talked earlier, where the blood groups don't match, but you can swap. Then the challenge, as we'll see later, is the deceased donation. The challenge here is mainly determination of death. So what are the ethical problems? Number one, invading a healthy body to obtain an organ for another. So basically, the donor is healthy, no disease, exposing them to a major surgery, donating a kidney, leaving them with one kidney, and in the future, this donor might contract another disease that was not expected, and is having an extra burden now. So those are the things that we grapple with when we're deciding whether somebody should donate or not. The other challenge is if from a related living donor, how could consent be obtained without coercion? So if, let's say, your sibling needed a kidney, would you refuse? Think about it as an individual. This is your sibling. You've grown with them for so many years. You're close to them. You've been asked by your parents, we want you to donate a kidney to your brother or your sister. Will you refuse? It's unlikely that you'll refuse. And why? Because this is your sibling. Is it coercion? It's difficult to come up with these issues. There's no real answer. And the other issue is, if from an unrelated donor, should there be compensation? Should somebody be paid, like, for example, the Yemeni poor driver who didn't have any money, and if only he could buy a taxi and he could support his family. The other challenge is from a dead donor, what is clinical evidence of death? Dr. Hooker, our neurologist here, might be able to guide us there, because there's a lot of confusion even up till now, but I think even in our constitution we've not yet defined what is death. So how can you extract a kidney when you don't even know what the definition of death is? As transplant become more efficient, how should recipients be fairly selected? How should sufficient number of organs be harvested to meet the need? So those are few challenges. There are more and more challenges we could discuss. So the international bodies have actually met to come up with some of these solutions, and one is the Transplant Society and the International Society of Nephrology actually met in Istanbul in 2008 to come up with what is called the Declaration of Istanbul. And mainly at this meeting they were looking at how to prevent organ trafficking, because there's a lot going on where one individual, the donor, let's say, comes from a poor country, the recipient comes from a rich country, they meet in a middle country where the transplant goes on, and these are some of the issues that we need to deal with. The WHO have also come up with guiding principles. There are 11 guiding principles. Because of the shortage of time, we won't go through them, but they're basically looking at the ethics and moral of donating kidneys. and the Madrid resolution that met in Spain in 2010 was mainly looking at donor advocacy, how to protect the donor so that the donor is not abused and mistreated. What does the Kenyan Constitution say? Up to recently, we were using the 1966 Human Tissue Act, which really doesn't say much. It was less focusing on deceased donation and how to allow bodies to be used by students in human anatomy. So we didn't have much until last year when the president accented to the health bill, which was looking at kidney donation, and as you can see, new law for organ donation to ease transplant pain. So although the law is out, the regulations are still not yet available, so we don't really know what to do with the law. And right now we've been promised that there's a body that is going to be formed, the Human Tissue Authority, where it's going to set up regulations in how we can organize ourselves and to do proper transplantations. So this is the constitution discussing the organ donation and transplantation. Transplant regulations are awaited. As I said, the government should take measures to combat transplant tourism and the problem of national and international trafficking in human tissues and organs. This is going to be a reality. As the number of transplants increase, we're going to see a lot of these illegal things going on, and that's why we need our regulations set up as soon as possible. Very quickly, in the last 1 minute, what does Islam say about organ donation and transplantation? As I was preparing for this talk, I researched, there was an article in the Saudi Journal of Kidney Disease and Transplantation in terms of ethics of organ transplantation and Islamic perspective by Khaja Quadri, and basically this issue has been discussed in several forums, and one being the Islamic Fiqh Academy, Muslim World League, which was held in Makkah in 1985, and they concluded that it is permissible in the Sharia Islamic law to remove the organ from one person's body and transplant it into another person's body in order to save the life of that person, but to assist in stabilizing the normal functioning of the basic organs of that person. So again, there are some authorities who actually are against transplantation even in the Muslim world. So with that, I've run out of time, and I'll stop there, and possibly we'll be able to discuss these issues later. Thank you very much for listening. us believe that the guidelines are too conservative, we support. So, as we said earlier, 80% of pulmonary emboli occurs as we refer to the site of symptoms. And a high index of suspicion is very important for us to be able to test early and to be able to save the lives of our patients. That's the most important part. And also the deaths in PE, they die within 30 minutes. So we don't have a very good time here to treat, react. So high index of suspicion is the next step of these type of patients. I'm talking about the criteria of diagnosis. I don't know if everybody does, but we use two criteria, Jones criteria and Christopher criteria. And these are some of the very important that these are individual points. They're not only for diagnosis, but some of them are for investigation, as you're going to see very soon. It's quite important, but let's not forget that majority of them have tachycardia. All those tests like S1 TB, they are not that are found in 10% of patients, but 4% of the is always high. As in your introduction of epilepsy, you might have a necessity of this, but we need to see some results. And in echo is quite useful, meaning that it's a non-invasive way of diagnosing it. And when it's the thing that we look for is airway penetration. We look at what the performance is and we can see that it's clearing the airway positive function. The rest of the airway does not do that. Pulmonary pressure, circulatory ventilation has to weather that acute PE. That PE that then that's very unlikely to be acute PE. That's probably acute on chronic. The pressure usually are mild to moderate, and sometimes we can actually see a clot or a thrombus in the RV, what we call thrombus in transit. And actually, as we talk, we have a patient in the ward who had a clot on the tricuspid valve. Okay, as we are discussing whether to thrombolize or not, the clot migrated to the pulmonary vessels. Okay, the gold standard of course is CT angiogram, and you can see the filling defects in the segmental vessels. And one is to do pulmonary angiogram, you can also see the filling defects on the main pulmonary trunks at times. Okay? So,
say anticoagulate. Because the government is paying, getting more. Other sick patients to have. The benefit was not seen, and this was where the problem was, because the benefit was negated by increased intracranial hemorrhage. Okay, if you look at an intracranial bleeding measure, 32 detonated place, which is a thrombolytic agent, compared to placebo, which was 60, and it was significant. Okay, and if you look at minor, the same thing. Okay, so there is benefit of thrombolysis, but that benefit is negated by increased number of stops. How do you check the balance? You can see how beautiful it is. A very huge subtle shaped thrombi there on the pulmonary tract. Even me, if I see that, I start panicking myself. You thrombolize the patient, look at everything has become so clear. So how do you get the benefit at the same time preventing those? So people thought of, why don't you do reduced dose of lysis? Rather than giving full dose, why don't you give 50% of the lysis? And all small studies have shown actually there is room for such an approach. There was a tendency towards improved mortality benefit for those patients who are thrombolized with half dose. So where do we go from here now? Planning a reduced dose like called catheter-directed thrombolysis, where instead of now thrombolizing through the vein, we put a catheter to the pulmonary artery and we slowly deliver the thrombolytic agent in a very reduced dose. And that has been found to be associated with better clinical outcomes. Focus on non-inferior efficacy. Compare half dose to catheter-directed thrombolysis. Focus on superiority safety. Compare half dose lysis to full dose lysis in massive PE. Maybe you'll get the benefit of thrombolysis, at the same time avoiding the negative effects of the strokes that were associated with the full dose. And of course, compare half dose lysis to anticoagulation. So we all agree that we are not defining our patients well, we are not characterizing them well. We want them to get the full benefit. But with the existing guidelines, we are missing high-risk patients, we are categorizing them simply as low risk because some of the parameters have not been given importance as others. Yet, studies have shown they are equally important and are actually associated with clinical outcomes. So, evolving strategies and regimens in catheter-directed treatment. So you put a catheter, and there's a study going on. We're going to infuse 4 milligram per lung over 2 hours, or over 4 hours, or take it to 6 milligram per lung over 6 hours, 12 milligram per lung over 6 hours. These are low dose. We are giving we are giving 100 milligram of alteplase, isn't it? So these are low dose that we're giving, but we're giving it directly to the thrombus now. What will these studies show? We are still waiting. These are ongoing trials. These are the gadgets that people use. You can see we usually use a pigtail catheter and has holes everywhere so that when you're pushing your thrombolysis through an infusion pump, it is released through that. These are other things that are more mechanical. So, patient with suspected pulmonary embolism. Anticoagulation should be initiated immediately unless there's a contraindication. Acute PE confirmed by CT, multidisciplinary pulmonary embolism response team, alerted, where we have interventionalist, cardiac surgeon, cardiology, pulmonary and critical care medicine. Okay? The member review the available medical information and develop optimal treatment plan. Then they decide this patient should be treated medically, catheter-directed therapy, or surgical embolectomy. Warning. Okay. There's also a study, what we call the extension of the PITHO trial, PITHO3 trial, that is looking at reduced dose of intravenous thrombolytic treatment for patients with intermediate high-risk pulmonary embolism. Now we are moving from high risk. We are talking of intermediate risk patients whom initially we'll have ignored. Okay? And we are eagerly waiting. This is a 2-year follow-up study. We are eagerly waiting for the results. And if one was to look at the post hoc analysis of the PITHO trial, even patients who had at least one severity criteria, here we're talking of troponins, BNPs, RV dysfunction, RV dilatation, you can see 27 deaths compared to 11 deaths. So they're still high risk. So these points that we actually underplay, they're not just that. We cannot use blood pressure as a criteria to decide the sickness of a person. The blood pressure has its own limitation. Who is taking it? What was the initial blood pressure? Are we clear? Is the guy hypertensive or not? Is he on treatment or what? So just using a blood pressure and deciding this is a very sick patient compared to the others and ignoring the rest of the evidence that we have, I don't think that's fair enough. Okay? And we have the issue now is not just to treat the patient during the acute stage, and several studies are looking at follow-up of these patients and looking at certain clinical things that will actually tell us our intervention is good or not good. ECHO, WHO clinical criteria, quality of life, 6 minutes walk, biomarkers, and exercise testing. I'm almost there. I think that's the next one. How can we safely exclude intermediate risk PE and discharge the patient early? Okay, we are using the same criteria, but you can see now we are adding something there. Sorry. If in the absence of RV dysfunction, in the absence of RV dilatation, then you can safely place that person to the low risk. And you can actually discharge the patient after close observation or few days of observation. And there's what we call the hot PE study that is going on now, where we diagnose acute PE, we admit you for some few days, but our aim is to discharge you very fast, do all those things, put you on rivaroxaban, which are the new novel anticoagulants, and follow you up. So this, I think, is the last slide, Mr. Chairman. So basically, this is going to look at whether we can safely treat our patients outpatient and discharge them, looking at these three regimes, where we're using rivaroxaban, apixaban, and warfarin. And the results will be presented very, very soon at the American College of Cardiology symposium. Thank you very much.
Thank you very much, Dr. Swale, for extensive talk. I'm getting a few messages to my WhatsApp, but one is saying that, Dr. where I work, there is no CT, no echo. What should I do? Number two, I'll make an announcement. There is a website called pigeonhole.at. I'm told there was a problem of people submitting questions. Some were shy, some were this. So you can submit your question over there. The people who are organizing will receive and they'll be answered. There's a code for that, 9QCYY7. So all of those who have smartphones can sign into that website, log in the meeting code, and then submit your question. We'll get them. We'll have 5 to 10 minutes questions, just in case there are any from the forum, and we'll kind of like the presenters, Dr. Marjan, Dr. Twahir, and Dr. Swale, to come over to answer any of those.
My question goes to Dr. Marjan. What does Islam say on the use of NHIF and insurance in general? We know that an employer, as per our constitution, is mandated to give employees NHIF or insurance. What if you are self-employed? Thank you.
In this aspect, Dr. Marjan has become an ectopic pregnancy from gynae to dialysis, please. We have not yet started receiving them from there, but for now you can start answering this.
Thank you for that question. I had the benefit. One time I attended Friday prayers at one mosque, and one of our presenters, who is a sheikh, if you look at the program, was the khatib, and he said this issue, that though a number of ulamas have said no to insurance, but also other ulamas have said in cases whereby there's compulsion, is mandatory, and it's not an Islamic state, then we have no option but to follow that, because like here we have car insurance and other insurances. But the one that you can avoid because it's mandatory, you can avoid. But what he said of NHIF was this. In my discussion about financing health care, there were people who will finance health care from out-of-pocket expenses. And the most popular one is mchango. You know, this is my relative, and then everybody will donate, and the one who is better, well endowed, will donate more, and so on and so forth. So he said, in that respect, particularly NHIF, since the design is social upliftment, in that the well endowed, perhaps Dr. Ahmed Twahir and I pay the highest amount of rates, that is 1,700 shillings. the lowest amount, I believe, will be about 300 shillings. So it is a way whereby the well-endowed support the one who does not have much. The one who is healthy supports the one that is sick. So in that respect, because it's not just a gain for what you contribute, or a loss even when you have contributed. He said in that case, some ulamas have said, particularly NHIF, not other insurance, is acceptable. And of course, you see, in everything, even in medicine, there are controversies. You'll find that there are controversies. In that same mosque, but this was side, I was not talking now to an alim. Every now and then, people will approach you as doctors. So one of the muaddins was telling me the wife had a problem, a medical problem. And I told him, look, I can help you once, advise, free consultation, even support you. But I might not be able to do it often, all the time. Why don't you talk to the leadership there to give you this support? In fact, I talked to one of the committee members, and he had the same problem, that one of the people who work in the mosque felt sick. And when they brought this issue of NHIF, some of them categorically said no, some supported, and there was a stalemate. That is the position. Thank you.
Any other question?
We just request that questions brief and answer be brief because the time is quite short.
I have two questions, one to Dr. Marjan and the other one to Dr. Swale. To Dr. Marjan, I was intrigued by your data on renal financing. I was just keen to know where you got your data from, which hospital, and because I've been looking for this data and I'm not finding it. And to Dr. Swale, are we overdiagnosing pulmonary thromboembolism? Are there issues of false positive diagnosis, especially from over-reporting by radiologists?
Thank you. I said this was a private hospital in Mombasa. In fact, I looked at 3 private hospitals, but I was not able to get some data from all 3. So I wanted to have a comparison.
You have to be careful. Sorry. I mean, even in our presentation last year with the Kenya Cardiac Society, I think there was a presenter who presented false positive CT scan due to artifacts and all that level of expertise interpreting the CT scans. But as I said, the approach should not be based on one. The same way the guideline is looking at BP as a criteria. If you have negative D-dimer, really you don't need to do a CT scan because the negative predictive value of these biomarkers is quite high vis-a-vis its diagnostic value. So I think for us, there is over diagnosis of PTE in CT, and we cannot just look at CT in isolation. We have to look at the totality of the evidence that we have. And I still believe the Wells criteria, the revised Geneva clinical criteria play a major role for you to decide. But overall, we also, if you're looking at over diagnosis vis-a-vis under diagnosis of PTE, I think the latter, under diagnosis, seems to be on the higher than over diagnosis. So I still believe high index of suspicion is the driving force for us to give our patient the best decision.
There is a question here to Dr. Twahir, I believe. Is the current ongoing collection of genetic database safe in terms of organ transplant? This is in case the data leaks or falls in wrong hands and can be used to target potential donors.
If I understand the question correctly, whether the ongoing collection of genetic database safe in terms of organ transplant, this is in case the data leaks or falls in the wrong hands. The two aspects on the genetics. One is to identify whether the donor is as related or unrelated to the recipient, and the genetics might be able to prove this or disprove this. I think one of the things that are clear when you're doing a kidney transplant is you must be very open and transparent to both the donor and the recipient. So you need to disclose all the information. So if you have information that is revealing, then you need to explain it to both the donor and the recipient. So if a donor comes out and let's say turns out not to be the son or the daughter of the recipient because of the genetic analysis, then it's important that this information comes out. The other component of genetic testing is because we now have advanced in technology in determining which donors might actually have potential risk of developing diseases like focal segmental glomerulosclerosis in the future, like for example, black Africans in America with MYH9 gene have got an increased incidence of developing FSGS. So if you do genetic testing in these individuals and you find this gene is present, should you disqualify them as a donor? And some centers have actually started doing it and disqualifying them as donors. So in areas like ours where we still have not done this type of studies, our black patients at risk of developing diseases in the future because we've not done this test and we're exposing them as donors. So this is a difficult question.
If there's no any other pending question, then we'll come on and Dr. Mali.
Yeah, two questions. One is about is what has been approved, came back as a review, which is now being reviewed by the health bill, which is reviewed this year, and the president did not assent to it, or that's already been confirmed and is in news about the organ transplant. And about the prevention. I think, of course, we have seen the diseases and the effects. But what are we doing about the prevention, particularly lifestyles? And I think that's what is very important also to be stressed much. I had breakfast this morning in Pride Inn, and when I see the way some of us eat, it's quite disheartening. I saw a female and a male, and subhanAllah, you know, I saw one person with a single plate. He had an omelette egg, he had a boiled one in the same plate, and everything. And you see the way we eat as if this is our last meal. And I think I like what Dr. Marjan started with the healthy eating. I think we also need to stress, particularly as Muslims, our lifestyles. Our eatings is really what is bringing us where we are, the bad habit of eating. And we know how we were taught, if you want to live healthily, how do you eat? Assalamu alaikum wa rahmatullah.
Okay, I think we've eaten to our tea time. We don't go for tea? Do we go for tea?
No, we already heard of overeating, so I don't know.
Oh, so we don't take any tea, eh? And I think we'll take this opportunity to recognize the president of the team from NHIF, Karibun, and I think this Dr. Kasim. Sezen, from the President of the World Islamic Health Union from Turkey. Welcome, and all of us. With that, I think, despite that being said, if you can grab a cup of tea and get back in 5 minutes. Possible?
I think you should not eat outside. If possible, take a snack and come. We're trying to keep time.
Yes.
We'd like to recognize the presence of World Islamic Health Union President Dr. Qasim, regional managers of the southern region from NHF, Mr. Douglas Owino and Ms. Mumbi. Thank you for coming. We'll have this break. I'll kindly answer one that came, young lady, postnatal, DVT, no risk factors, risk of anticoagulation. There is a risk, but it is small if you can anticoagulate. Warfarin, Clexane, or novel anticoagulants, any of those three that they can afford. Okay, thank you very much for this session. Sorry, I'm seeing another hand, but if in case you can address any of the speakers as we are having tea, please do so. Thank you very much, and let's please keep time and be back. Thank you.